Welcome to our November M&M. This month we're going to be talking about, just drag you guys off the screen. No one wants to look at you. That's interesting. It won't let me minimize it. All right, that's fine. Welcome to our November M&M. Today we're going to be talking about ketamine cases. Not any that are like from our specific system or region. These are all cases that so per usual, please follow us on social media, TH of any EMS on Instagram or Trinity Health of any EMS on Facebook. And then the new website, mercymedcon.org, which hopefully some of you are starting to utilize. A couple slides I have to put in for continuing education purposes. So mercymedcon.org is now live. You can scan the QR code to get there or just type it into your phone. As soon as I see people with phones down, then I will tell you what's on there. So this is going to be, it's nothing fancy. It's basically just links to other things. So probably the most important one that I would appreciate if you'd all take a moment right now, go to mercymedcon.org, tap join to add yourself to a mailing list so that we can update you with things like upcoming M&Ms, other educational announcements, other important system or other announcements. We're not going to spam you. Honestly, I'll probably only get around to sending something out like a few times a year. But just want to be able to have that resource so we can talk directly to the folks that are working on the ground instead of having to filter through hoping that your supervisors have to forward something to you because they're very busy too, right? So that's available. If you want to look at previous recordings of M&Ms, you can just follow the link to that'll head you to the YouTube channel with a playlist of all the M&Ms on there. And then we got forms for if you want to request follow-up on a patient that you dropped off at Mercy. You just fill up that form electronically, and then it'll come to me and Renee, and we'll get back to you. If you have an interesting case that you want to submit to us, like an interesting EKG or something else like that, you can submit it there, and there's an option to attach an image. For National and Chapin folks, when you go live with the trauma gel sometime next month, if you don't have another way to get to the survey to fill it out, you can do that. Then at the bottom is the link to our calendar where you can register for all of our educational sessions, which in addition to M&Ms, we're going to be doing a journal club a couple times a year where we talk about recent or classic EMS research papers. And then that's also where you would sign up for new hire Crike class, which are going to be held quarterly, starting as of this quarter. So join the mailing list, new classes, other relevant updates. So when you're dropping a patient off at Mercy, if you want to restock meds while you're there, used to be that you would have to bug the charge nurse to get into the EMS Pyxis for you. Now all nurses have access to the EMS Pyxis. So you can ask any nurse, the one you give report to, someone in the hallway to just grab Zofran, anything that's not from the controlled box, they can restock it for you out of the Pyxis. Another pro tip, if you're trying to get a hold of us from MedCon, you don't have to go through CMed so that it gets recorded. If you call either of our numbers, which are listed there, those are recorded lines. So they meet the requirement for the conversation with MedCon being recorded. So you don't have to add the extra step in time of going through CMed. So that's already going to save you several minutes in trying to get a hold of someone. Just call us, it goes directly through, and then they can try to get a hold of someone. So that'll save you some time. If you're trying to get a hold of MedCon, you can just call us. You don't have to go through CMed. Now, probably the most important announcement that I was told this morning. Mercy is suspending all labor and delivery services as of December 8th. That's all I know right now. I literally got the email this morning with the announcement that that is the date it's actually happening. So starting December 8th, none of this. Don't bring us any babies like that. Newborns, imminent delivery, precipitous delivery. We are still going to have GYN coverage 24/7. but we will not have OB labor and delivery coverage. So those patients will have to go to Bay State, and then we're going to have to work out plans for transfers and that kind of stuff. But so December 8th is when that transition is actually occurring. All right, moving on. So we can go ahead and get started. If you guys want to whip out your phones and scan the QR code so you can participate in the polls. I've dropped the link for the polls in the chat a couple times. So you can also if you're on Teams, you can just click on the link. All right, so let's see if that works. Hey, looks like it's working. People are mostly doing okay today. I'm glad no one's on the frowny end of the spectrum yet. All right, so like I said, today we're going to be talking about ketamine cases. I'm a doctor, not a lawyer, so I'm going to be keeping this to the medical parts of the cases. There are questions about the legal aspects of the cases that I can't find answers to and that frustrate me, but I'm going to try and not pontificate on that part. We're going to focus on the medicine, what happened, how it could have been prevented. So the problem, particularly with ketamine in the media, is that it's one-sided. The reporting is very one-sided. And sort of regardless of, and you'll see through these cases, regardless of what does or doesn't happen that contributes to a case, it's still going to be reported about the ketamine because that's what gets people to watch, right? Because it's clickbait, rage bait. So what have you heard about ketamine or seen in the media or talked about with people on shift? People go to jail for it. That is true in one case, yeah. Anything else? Potentially huge liability. Any easy to overdose, you said? Yeah. Okay. Any comments online, Renee? No. Okay, crickets. So how many times have you given ketamine personally for any indication? All right, so it looks like most people, for the most part, people are, we'll say, ketamine naive, because you haven't given it a ton. Okay, that's good to know. So the first case we're going to talk about is Gwen Donor from Utah.
Listen to this. Parents of a 19-year-old who died in 2021 are now suing first responders and medical organizations in Murray, saying after their daughter Gwen Donor was hit in a head-on collision, she was given an improper amount of a drug called ketamine they say would ultimately kill her. Fox 13 News reporter Lucy Nelson sat down with Gwen's mother today to hear why they are filing the lawsuit.
It's been excruciating. I mean, losing a child is the worst possible thing you can go through.
Oh. Heather Myers is trying to move on without her 19-year-old daughter, Gwen Donor.
She loved the world. She loved life. She wanted to help people.
Gwen was hit by a wrong-way driver traveling eastbound on I-215, but contrary to what her mother was told, medical records would show she did not die from the injury sustained in that head-on collision.
When we first arrived at the hospital, she was there. She had broken bones in her legs and one arm, but we were told she was going to be just fine. She was going to wake up.
By that evening, things took a drastic turn for the worst. Gwen didn't wake up and never would, leaving Heather in a state of grief and confusion.
It's just the doctors never could clearly articulate the link between those injuries and then after hours and hours of saying she's going to wake up and she's going to be fine than telling us the exact opposite.
That's when Heather sought help from lawyers, filing for medical records, which revealed her daughter died of anoxic brain injury. She says she would later learn first responders gave Gwen 16 times the maximum dose of a newer drug called ketamine after the car collision, which would cause her to overdose and go without oxygen for 7 to 10 minutes.
I believe with all my heart that they were trying to help her, that they were doing the best they could, but unfortunately, a fatal mistake was made.
After battling for months, lawyers finally obtained body camera footage of the response to the crash, where a paramedic with the Murray Fire Department said she gave Gwen 500 milligrams of ketamine, saying she wasn't supposed to give her that much. So anyway, she stopped breathing now. I reached out to all 7 organizations listed on your screen, and of the ones who responded, they said they could not comment on pending litigation.
To this date, no one has ever reached out to tell us the truth.
Myers says she is fighting for more clarity from medical institutions.
This entire experience has been a devastating betrayal of trust.
And training for first responders.
It's like, why was drawing 500 allowable? Why weren't there oxygen or other breathing apparatuses nearby?
The reason she is suing?
I mean, of course, I want my daughter back, but at this point, we're just going to have to settle for change so that this doesn't happen to another family.
In Murray, Lucy Nelson, Fox 13 News.
And then here's the follow-up.
New at 6 tonight, the mother of a woman who died 2 years ago talks to 2 News after launching a lawsuit alleging that healthcare workers gave her daughter 16 times the maximum dose of ketamine normally allowed. Thanks for joining us for 2 News at 6. I'm Mark Cabell.
And I'm Heidi Hatch. 19-year-old Gwen Donor died on April 19th of 2021 in a head-on wrong-way crash. The driver in that crash was sentenced 20 to 30 years in prison. The issue now, her parents say Intermountain Healthcare, the city of Murray, and others gave her 500 milligrams of ketamine during that care. In a 2 News investigation, Darby Sparks spoke with Gwen Donor's mother to get her side of things. Darby.
Mark, Heidi, I'm in front of Intermountain Healthcare right now, where Gwen Donor was sent to on the night of that crash. Intermountain Healthcare is one of the agencies being named in the wrongful death lawsuit that Donor's parents have filed.
I believe it's a systems failure.
Heather Myers, the mother of 19-year-old Gwen Donor, and Donor's father have filed a lawsuit against multiple agencies after they say the emergency measures taken to save Donor's life proved to be fatal.
There was a very unfortunate series of mistakes.
Upon being hit by a wrong-way driver in Murray on April 19th, 2021, the lawsuit claims Donor was given 500 milligrams of ketamine by an EMT. The lawsuit alleges that the dose caused Donor to become unable to breathe, and for 8 to 10 minutes she was without oxygen.
Her death is consistent with an anoxic brain injury.
2 News tried reaching out to Unified Fire Authority, the organization responsible for responding to the crash, to ask these questions. How does a paramedic accidentally give a dose 16 times the normal amount? How did Donor go without oxygen for a substantial period of time, and what went wrong? But they denied comment. Upon arriving at the hospital, Myers says that the doctors told them Donor had multiple broken bones and needed surgery, but should make a full recovery.
It was a total of 4.5 days that we were at the hospital with her there, and not once was an overdose mentioned, the time she went without oxygen.
We also reached out to Intermountain Healthcare System to ask the questions. Why didn't you inform the family that Donor had been given a lethal overdose? Why did you say that Donor was going to wake up after the surgery when she was dying from that overdose? They gave us a written statement that said, in part, due to pending litigation and federal laws, we're unable to respond to specific questions. We can say, however, that we're always committed to providing the safest and highest quality of care for all of our patients. But for Myers, that's what the lawsuit is about, assuring all patients can trust that they're in good hands.
It's about truth, it's about accountability, but more importantly, it's about improving those safety training procedures.
The city of Murray has also been named in the lawsuit due to the involvement that police had in the crash. We'd like to ask them a few questions as well, but they forwarded us to their attorney, who did not respond. Live in Murray for 2 News Investigates, I'm Darby Sparks.
Darby, thank you. When this wrong-way crash killed Gwen Donor, we talked with her father and her uncle, who reflected on the support they saw in the days following that crash and how they remember her.
The outpouring of love and support is just amazing. our family was just so proud and excited because she knew who she was and where she was going.
We do have several news articles still online looking into what led up to that crash, as well as when the driver was in court just last year. You can find those stories at KUTV.com.
All right, so let's talk about what happened. So this was a head-on freeway MVC. There was city fire and life flight on scene. The patient received 500 milligrams of ketamine IV, became apneic, and then had a cardiac arrest. After ROSC, had an anoxic brain injury and was eventually declared brain dead. So doing the math of, they keep saying 16 times. So that's, when you do the math pretty clearly, what they were intending to do was give 30, which we know is the pain dose, right? So instead of the pain dose, they got the behavioral dose that should be given IM. So what do you think, how do you think that could happen? Any thoughts? Yeah? Late at night, your circadian low, 3 a.m. brain. Okay, that's one possibility. Anyone else? Too much chaos on scene? Yeah? Not confirming, lack of closed loop communication. So that's exactly what happened, but it's also a little bit more than that. So at the time of this incident, ketamine in the fire department protocols was only for behavioral health, and life flight used it for behavioral, RSI, pain, whatever they wanted. So when they said, we need ketamine, fire went, okay, I can get you ketamine. Here's ketamine. It's the only ketamine they know is 500. And then life flight, without the closed loop communication, gave the whole thing because they thought it was 30, which is what they meant. And that was not clearly communicated because difference in protocols between two agencies working together. So that's what happened. Now, the other issue is the recognition of the apnea. What apnea was unrecognized, right? Now, I will say that the patient getting too much ketamine and going apneic, a trauma patient getting too much of a sedative hypnotic medication is not unique to ketamine, right? This could have just as easily happened with fentanyl, Versed, anything, right? The ketamine, they said lethal overdose of ketamine, right? Only in the same way that people die of other overdoses, right? It's not the medication itself that is fatal. It's the lack of oxygenation and ventilation afterward, right? So the apnea was not recognized, and there wasn't, right, any proper airway management. I said ongoing civil suit. So going through some of the filings and pulling out quotes and stuff, because obviously none of the transcripts and stuff are publicly available, but the filings are, and sometimes there's quotes in here. So this is what they said after they realized. I have a problem. I gave her 500 of ketamine. I told her what it was. She gave her the whole damn thing. She wasn't supposed to give her that much. So anyway, she stopped breathing now. So I need someone to get me some intubation equipment to intubate her. Which means, number one, they recognized the error in the closed loop communication. But number two, that means they didn't have their airway bag with them, right? You were giving ketamine without being ready to manage the airway, which is probably the real error here. So have you ever seen a patient go apneic after getting ketamine? Okay, mostly no. And that's true with my experience as well. For the most part, they don't. The people that go apneic from ketamine, apneic, it's not from a loss of respiratory drive. It's because they have sleep apnea or otherwise obstructing the airway. This isn't central apnea like with opiates or benzos. This is usually obstructive, right? Because if you have obstructive sleep apnea and they give you a drug to put you to sleep, you're going to obstruct. It's in the name, right? So I do this in the ER. Like if I'm going to sedate someone for a procedure, I'm like, hey, do you wear CPAP at night? Yes. Okay. That means when I put you to sleep, guess what? They probably need CPAP. So I'll have RT put them on CPAP because like they need that. We know that. This is a diagnosis, right? So the teaching points from this case, dose and route obviously matter, right? Giving 500 IV is not quite the same as giving 500 IM. Would you push a med that someone else drew up? Well, depends on the working relationship, okay? Right? So this is a big thing, right? Like, are you going to be comfortable with drawing a med that someone else drew up? I think it matters a lot with what the med is, the potential for error, right? So hoping that that is actually the med, right? So there should probably be some confirmation, like showing the box or the vial of like, no, this is what I drew up for you, or only doing it yourself, right? Is another option. And with ketamine, you must always be ready to manage the airway. Okay. With any pain medication, benzo, ketamine, right? They're all kind of in the similar class. You always need to be ready to manage the airway, because when you're taking away that stimulation, as soon as that stimulation is gone, they can go to sleep, which is sometimes, right? That's exactly what we're looking for a lot of the time. But that can lead to airway compromise. So you have to be ready to manage the airway. All right, second case, James Britt.
County facing a new lawsuit in connection with the death of a man in Mount Pleasant. Live 5's Emily Zuowski joins us from the newsroom to tell us what the man's widow is asking for.
The new lawsuit concerns the 2019 death of James Britt Jr. Britt died more than a week after he was injected with a sedative called ketamine by EMS following an incident with police off Highway 17. Lawyers for the town of Mount Pleasant claim he was intoxicated near a car and caused injuries to both himself and an officer. The Charleston County Coroner's Office ruled this death a homicide that was caused by restraint asphyxia and the toxic effects of ketamine. Now, attorneys for Britt's widow want an injunction to stop Charleston County EMS from using ketamine in the future in connection with law enforcement objections. The town of Mount Pleasant already agreed to a $3 million wrongful death settlement in connection with this case. This all comes as ketamine has increasingly been used by EMS in many South Carolina counties, with doctors saying it can be an important tool to sedate patients, but only if it's used properly. We reached out to Charleston County for comment, but we have yet to hear back. Reporting live in the newsroom, Emily Zuowski, Live 5 News.
We just received a statement from James Britt's widow. She says, "My family is still grieving from the loss of my husband and how inhumanely he was treated. This is a tragedy that no one should ever have to go through." End quote.
All right, so let's talk about the facts in this case. So 911 call for a man urinating in public. That's what this is all over.
Dose him.
That's how this started. So, police detained the guy for public intoxication. He blew 274. So, yeah, okay, he's drunk. Had to relieve himself, as one does, right? When you gotta go, you gotta go, to quote Jurassic Park. So he got restrained by police, got 500 ketamine, became apneic, went into cardiac arrest. After they got Ross, he was found to have an anoxic brain injury. You're going to see the theme here. Okay. So the civil suit, EMS, quote, without doing any medical evaluation and without assessing whether a medical need existed, gave ketamine to sedate the decedent. Right. So they determined that the defendant administered a sedative while this decedent was being arrested, not while he was being treated or evaluated for a medical condition. That's how the suit went forward.
New at 6, the town of Mount Pleasant is paying a family $3 million after court documents show a man died following an encounter with Mount Pleasant police.
The incident that happened last September is part of a wrongful death settlement.
Alexis Simmons in Mount Pleasant for. So Alexis, what's the latest with this case?
Annabelle, the state law enforcement division says they are still investigating this case and they are in the final stages. Now, we've requested these incident reports from the Mount Pleasant Police Department. They have yet to turn over those documents, but here is what we know about this settlement. Court documents say James C. Britt Jr. died on October 8th of last year following an incident with Mount Pleasant Police on or around September 30th. The Charleston County coroner ruled his death as a homicide and said Britt died from restraint asphyxia, which means being deprived of oxygen, and the toxic effects of ketamine. The attorney for Britt's family says Charleston County personnel administered that ketamine, and a case against them has not yet been filed, but will in the future. Ketamine is used as an anesthesia medicine. The coroner also says other significant findings for his cause of death include obesity, toxic effects of alcohol, hypertensive, and cardiovascular disease. The family's attorney says they were able to reach the $3 million settlement without a lawsuit. Now, in a statement, attorney Mullins McLeod said, quote, "The significant settlement marks the first step towards complete justice for Mr. Britt's untimely death." And the town of Mount Pleasant says they do not have a comment on the settlement. We've also asked for a comment from the police department. They say they've turned over our request to their legal department. I'm reporting live in Mount Pleasant. Alexis Simmons, Live 5 News.
Right. So toxic effects of ketamine, quote unquote. If that guy had been given the same dose of ketamine when he wasn't drunk and being restrained, do you think they would have had the same problem? No, for sure, but probably not, right? Right, like, would Matthew Perry have drowned in his hot tub, would have died from his ketamine overdose if he wasn't in the hot tub? Probably not, right? Like, so it's not the drug itself, it's everything surrounding it, right? So think of this as you're giving someone a whopping dose of Versed, right? They could go apnea, right? So we need to be prepared to manage the airway. So where are your airway bag and monitor when you give ketamine? Right now in your practice, not where you want it to be now that you've talked about these two cases. Normally in your actual practice, where is it? With me, ready to go. Sure it is. So most of you, I hope, are telling the truth, and it's right next to you, ready to go. Like you're ready to whip out that BVM and bag the patient if something goes awry. So the teaching points in this case that co-intoxicants, alcohol, any other substance, increases the risk of adverse effects from giving ketamine. So if they're on other things, which a lot of patients that are getting ketamine are, especially if it's behavioral, there's increased risk of adverse effects, right? Because it's like if someone is drunk and belligerent and you're giving them Versed, right? Like think that maybe they'll get oversedated. Could happen with ketamine, but less likely. That's why we use it, because it's safer and in general is extremely safe, but the risk is not zero. Particularly from this case, ketamine is a medical intervention that requires medical assessment, right? And so you have to be thinking, why am I giving this drug? What is my working diagnosis that I'm running with to treat what, that then dictates the protocol that the patient is being treated under? So, I think this patient has severe, delirium with severe agitation. He's clearly a harm to himself. And I am doing this so that I can facilitate getting a full set of vital signs, point of care glucose, establish access, and intend to transport this patient to the ED, right? It's not put him down so that he can get arrested, right? Which is sort of what happened in this case, or what was determined to have happened. So again, you're EMS and you need to be doing a medical assessment for medical intervention. Your interaction with law enforcement on scene, you need to make sure that the ketamine is being given for the right reason, right? That it's not to facilitate something that they're doing, that there's more a clear handoff and decision-making around why something's being done. Okay, Werner Anderson. You're just gonna have to, there's no good news clips for this one, but it's still a good case. So, first 911 call was for a man swinging his backpack at passing cars. He was super high on meth and stated that he used meth recently and liked sprinkling it on his eggs. So the cop that picked him up just drove him to a shelter and dropped him off. Right? He's just swinging his backpack in traffic. They're like, dude, just go be yourself somewhere else. Go live your best life. Just stop bothering people. Okay? Reasonable, right? Second 911 call for assault, quote, very high on meth outside of a shelter. So, cop arrives on scene. Patient was trying to get to his feet, but was only able to roll around, grabbed a bottle of water, and started trying to drink it, with half the water going in his mouth and half the water being poured on his person. Stated he was sweating profusely and talking incoherently and moving on the ground like a dolphin. So EMS got there. For some reason, the patient was in the captain's chair. He got up, stepped between the wall and the stretcher, so I'm assuming like the narrow side, then lunged towards the back of the ambulance and fell between the stretcher and the wall of the ambulance. Yeah, you're all giggling because you're going like, oh, I could totally see this happening. Right? Firefighters opened the back door and took out the stretcher, rolled the patient onto his stomach, who was yelling, cussing, and struggling with officers. He got 250 of ketamine, became apneic, went to an arrest. They did not get ROSC. Now, the toxicology report showed that the ketamine levels were, quote, consistent with the fire department protocols. But the meth level was, quote, fatal range. But what do you think is going to get reported in the news? Ketamine, right? Fatal amount of meth. If you'd given him a saline flush, he probably still would have arrested and died, right? So, have you ever given ketamine to a patient who was intoxicated on anything else? No? You don't think you've ever given ketamine to someone who might have been on cocaine? Okay, maybe, yeah. Yeah. Right, and the difficulty is that, especially pre-hospital, like, we don't know, right? I don't know, is this their organic psychiatric illness because they've been off their meds? Is this some sort of precipitated psychiatric issue from them doing drugs? Is this all agitation from being intoxicated on something? Are they just really wound up? I don't know, right? But remember that, again, the co-intoxicants, meth, cocaine, cannabinoids, alcohol, all increase the risk of adverse effects. And even if the ketamine is effectively a bystander, the ketamine's going to be what gets blamed. All right, so we'll move on to the big one here, Elijah McClain. So this is Aurora, Colorado. This is where people went to jail over this.
Stop right there. Hey, stop right there. Stop. 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 I have a right to stop you because you're being suspicious. Well, okay. Turn around.
In July, Colorado's health department opened an investigation related to the death of Elijah McClain.
He's drawing up ketamine right now.
Okay.
They wanted to know why the 23-year-old had been given a large dose of ketamine before his death. The drug is a powerful sedative used by paramedics throughout the country. It's hard to know exactly how prevalent its use is because it's regulated differently from state to state, and there isn't much information sharing. But everywhere that it is used, it's supposed to only be used in specific cases. And victims who, unlike McClain, have lived to tell their story, are starting to speak out about how it's being used more loosely than it should be. John Powell, who lives outside Minneapolis, was given ketamine during an arrest back in 2015. Powell was at the hospital visiting a relative who'd been shot when police apprehended him. Officers had received a complaint about a white or Hispanic man. Powell, who's black, didn't understand what was happening. Police say they mistook Powell's car keys for a gun and that he wasn't following orders.
I'm kicking on the door in the window trying to get my wife's attention. He called the paramedic over. He talked to him for maybe 2-3 minutes. The officer put his gloves on, opened the car door, grabbed my arm, I was handcuffed, pulled my arm out of the car. And the paramedic stuck it in my arm and pushed it in. He never even looked at my face. They said I was acting belligerent. I stopped breathing right away as soon as they shot me with it.
What happens when you wake up? What do you learn?
I see my wife sitting there crying, my kids, my mom, everybody sitting there crying. They ain't never left the hospital. The first time she seen me, I had all these tubes down my throat and I was in a coma. We filed a lawsuit against the ambulance people. They paid me like $50,000, $60,000. I used that money to fight against the police.
A judge dismissed Powell's case, ruling that police had reason to stop him, didn't use excessive force when detaining him, and had no involvement in the decision to sedate him. It is technically on EMS to decide when ketamine is necessary, and since paramedics are the ones who administer drugs, not the police, it's hard for anyone to win a lawsuit against police for the use of drugs. But the relationship between paramedics and police officers is a tricky one. And there's evidence that police are doing more than just asking if the use of ketamine is necessary. In 2019, paramedic Joe Baker was called to a scene where he says police told him to give someone ketamine even though he didn't think it was medically necessary. He refused and says he was later forced to resign. He's now suing the department, which denies his account of what happened.
I didn't feel comfortable drawing up ketamine prematurely because I had not medically evaluated that patient. And the police officers were really frustrated with the fact that I wasn't going to go along with it. What ultimately resulted was I was placed on corrective action because I was insubordinate for not following the directives of the police officer.
Do you worry that police officers are instigating the use of ketamine more often than it should be used?
Police officers shouldn't be requesting it or suggesting it. I understand the situation that they're in where they may have an uncooperative individual that they have to deal with, but if the situation dictates that ketamine should be administered, then the paramedics are going to recognize that.
In Minneapolis, the Office of Police Conduct Review recently found multiple cases in which police had either requested the use of ketamine or were asked for their opinion, neither of which is supposed to happen. But it isn't just the overstepping of boundaries and expertise that's under scrutiny. The American Society of Anesthesiologists doesn't think ketamine or any sedative should be used in these situations as a law enforcement tool. Jamie Kennel, a professor and former paramedic, still thinks sedatives are useful and relatively safe, but he sees the issues too. When is a sedative like ketamine supposed to be used?
In this particular case, most systems reserve its use for the case of excited delirium, which is kind of a catch-all for acute agitation, unpredictable behavior that you're unable to often verbally de-escalate. A lot of the diagnosis is based on clinical impression, which is a vague, squishy science. As EMS agencies have to balance a number of things in order to choose appropriate drugs. In a sedative situation, they need something that can act quickly so that the patient remains safe and the crew remains safe.
Are certain groups of people more susceptible to excited delirium?
There's a social component on who gets diagnosed and who doesn't. And for the African American community, especially for young males, there is a common stereotype of aggression, of violence. I think there's some evidence around overestimating weights, overestimating physical force that may suggest that members of this community are probably more likely to be sedated.
How has what happened to you affected your life?
Mentally, I'm still not stable. Every time I see police brutality on TV, I think about it. And it's like fresh in my mind. It don't leave you. I wanted to fight them regardless. If I didn't win, I didn't win. But I wasn't gonna not try because I know what they're doing to people is wrong.
Ketamine result in bad outcomes but don't get the same attention.
That's a good point. So the comment from online was, how many people are getting something other than ketamine and having a bad outcome? We don't know. So, what happened in the Elijah McClain case? He was restrained by multiple police officers. He got 500 ketamine with apneic, cardiac arrest. Then they got ROSC, and eventually the patient was determined to have an anoxic brain injury. So their protocols for 5 mg per kg, they estimated his weight to be 100 kilograms. His actual weight was 85 kilograms. Some of the interesting things from the filings and what's been released afterward were he was taught 3 ketamine doses, 300 milligrams for small, 400 milligrams for medium, and 500 milligrams for large. And this is another interesting kind of systemic one when they're talking about drawing from the med. He was over the 400, and with a 5 cc syringe, there were no increments on there to measure exactly, right? So there's a couple issues. Number one, that the protocol is dictating very strict weight-based guidelines, right? And so you need to actually estimate a patient weight, which we are very bad at doing, right? Everyone is, except the guys at the carnival. I don't know, maybe they should do EMS. So in order to deal with that, sometimes we're reverting back to like a fixed dose, right, strategy. And then there's another issue here with drawing off medication. I'm assuming that theirs is the 510, possibly. So they're trying to draw up like 4 and some fraction of cc's, but there isn't like a marking in between. So having the right equipment for drawing up and delivering the met, right, to be able to measure it accurately. So at 22:59, the patient was injected with ketamine IM. 2 minutes later, body cam shows the patient was unresponsive but breathing. 1 minute later, the patient was vomiting. They were still outside of the ambulance without any airway equipment. 2 minutes after that, the patient had the patient loaded in the ambulance, but he was apneic and now pulseless. 13 minutes after that, they arrived at the ER with ongoing CPR, and then 5 minutes after that, they had ROSC. Then 3 days later, he was declared brain dead. Not because that's how long it takes for brain death to occur, it's because that's how long it takes to determine. So end to end, from the time that they gave the ketamine, loading the patient, vomiting, transport, arrest, and ROSC was 23 minutes. But that's fast, right? That's shorter than sometimes a morning poop, right? So this moves very, very, very quickly. Have you seen a patient vomit after getting ketamine? Yeah. Did they say why they didn't run the code on scene when it was recognized? I believe because they already had the patient loaded in the ambulance, and they said they figured like make a run for it. Because also I didn't add like the transport time in there, but it was they were like around the corner basically. So it was kind of like we're already in the ambulance, just go for it. So most people haven't. It's fairly uncommon after getting IM ketamine. I do see it occasionally when I'm giving IV ketamine for sedation. So I often, if I'm giving it IV, I often give it with Zofran, kind of upfront. So it's unusual. It's a little unusual, but it does happen, particularly with IM doses. So the findings and recommendations from the whole investigation and the inquest into this particular case. One of the issues was delays in clear transfer of control from police to EMS. So again, cops called EMS because this guy's fighting too much and he needs to be sedated. EMS arrives, and again, it's a medical intervention that requires a medical assessment. So, what are they treating? What's their protocol? What are they treating? Where are we going with this? And so part of the recommendation coming from that, so the delay in transfer was essentially saying, hey, we're going from this person being a suspected detainee to being a suspected patient. Okay, and that wasn't there wasn't a clear transfer or delay in that. And their recommendation was around building a culture of patient advocacy, right? And that's sort of more on the EMS side of the house of like advocating, like, is this a patient or is this a detainee? Lack of clear communication and possible information loss between Aurora Police and Fire. So, like, they didn't have a whole lot of information when they got there. They basically said, this guy's fighting too much, and so he's obviously a risk to himself, like we need to put him in the K-hole. Without trying to get more history of, all right, exactly what happened? Do we know if he's on anything? Does he have a medical alert bracelet on, right? And so they recommend that there be a formal transition process or like a handover, essentially, right? So that you're getting the information that you can from police as that person is being transitioned from being considered a detainee to being considered a patient. Delayed and incomplete patient assessment. Because again, they basically, if you look at kind of how things were laid out, they pulled the ambulance up. The stretcher was like halfway to where the scuffle was happening. And then they pulled out the meds and then went to the patient. So the airway stuff was on the stretcher over there, which was halfway back to the ambulance. So they didn't have their monitor. They didn't have any kind of monitoring on the patient or available at the time that they were giving the drug. So recommendation, a complete pre-sedation primary assessment, including cardiac and respiratory monitoring when feasible, right? Odds are if you're giving behavioral dose ketamine, that's not feasible, right? But even if you can so much as feel a pulse or look at their carotid, right? Get some idea of, skin color temperature condition, right? Are they dry? Are they super diaphoretic, right? Where is the patient at right now? Is there anything that's going to give me any additional information to aid in my decision making here? Highest priority should be given to the completion of a primary assessment and initial vitals following sedation where an assessment is not feasible in advance. So meaning most of the time, like as soon as you give the med, you got to get the patient fully monitored, end tidal, full set of vitals. That's when you're right when they're like going to be the most sedated. So when you're going to get in your POC, getting your access and everything, and ready to go. This is not a scoop and run. This is the most critical time. Is the time that between when the drug is given and when we can be fully monitoring the patient for any effects of giving the drug. So that was another, I think, so the question was, did anyone try talking to the patient and verbally de-escalating? That's sort of another finding from this. I believe we'll get to that, but in sort of like the de-escalation process, right? Sometimes it's different, right? Because you're not a cop, right? So sometimes it's a little different. You're maybe able to disarm things just by virtue of not being a cop, right? So that's always we're trying first. But in this particular case, I think that's part of the findings was there was not sufficient efforts at verbal de-escalation before going directly to the medication. Failure to obtain appropriate equipment. So like I said, they didn't have their airway bag, their monitor to monitor the patient at the point in space and time where they were giving the medication. And then inaccurate estimation of patient weight. I take a little bit of issue with this because there's nothing really magical, because you look at all the different protocols and research and studies right out there, all of this stuff is in ranges, right? So there's going to be acceptable ranges, which means that it doesn't mean you have to have an exact accurate weight to be able to do this safely. Because I'll be honest, I do fixed dose based off of their kind of general appearance, like small, medium, large. That's what I do in my practice in the ER. Because again, it's not the med, it's the effects of the med and the monitoring afterward. But they talked about cognitive shortcut of dose rounding has supplanted the specific ketamine dosing outlined in the protocol. So consistency between education, execution, and evaluation of protocols is important to mitigate risks associated with poor clinical outcomes, misinterpretation of guidelines, and failure to recognize or remediate protocol deviations. So the main issue here is that if the protocol says you're supposed to be doing weight dose, then you need to be doing weight dose. You need to estimate a weight and then give a dose based on that estimated weight. Not just saying, I'm just going to do this instead because it's easier and that's my medical director said he does in the ER. Again, in my practice and what I do in the ER is fixed dose based off of general size because I'm allowed to do that. But the state protocol is weight-based dosing, so it's got to be weight-based dosing. And we'll talk about that a little bit more when we get to that section here. The role of cognitive errors in medical decision-making. Has anyone ever heard of like anchoring bias, diagnostic momentum, or confirmation bias? So all those things are kind of wrapped together. So anchoring is the first thing you think is the thing that you hold on to. So this guy's fighting the cops. It must be because he's on some. This guy's fighting the cops. It must be because he's severely agitated, right? Diagnostic momentum is going forward with that and kind of ignoring other things. Like, oh, what are all those needles he has on him for his insulin, right? Who knows? And then confirmation bias means that everything that you're looking for and you're finding the results of, you're only looking for things that are confirming what you already thought rather than second guessing or questioning what you were going in with, right? So this is more about keeping your differential broad when you're seeing an agitated patient, right? So is this strictly behavioral? Is there substance involved? If there is substance involved, are there secondary sort of metabolic consequences that they're super tachycardic, diaphoretic? Are they diabetic? Do they have a bloodstream infection, right? They look like they're burning up and flushed and they're delirious from fever, right? So what else is or could be going on with the patient that I need to think about? They recommended using a checklist, which included early monitoring with end tidal, point of care, temperature plus temperature management. So if the patient's hyperthermic, cooling them, O2 fluid bolus and trying to correct suspected acidosis, which is all what we should be doing, right? I mean, that's super reasonable, right? For any patient that is like diaphoretic, tachycardic, fighting, agitated, confused, like that's just good care, right? But it's very easy to forget to do that in a formalized way, and that's why we use checklists, right? Questions, comments about the Elijah McClain case? No. All right, let's take a 10-minute break. We'll come back at 11:05, talk about some of the research that's on ketamine, review protocols and dosing, and wrap it up. All right, let's come back in and get this going. So let's talk about the science, the research into this, into the use of ketamine in the pre-hospital setting, because these cases have sparked a lot of interest in, is this happening more often? Is this common? Or are these outliers that are being amplified because of errors that were made? And is this more of an emotional narrative or a narrative around the whole event rather than the science of the drug and what's actually happening in the stats? So you have a patient with extreme agitation, aggression, and confusion that can lead to sudden death. What is the diagnosis? Hyperactive delirium with severe agitation, excited delirium, or UTI? Okay, so good. So most people going with excited delirium, about 25% with hyperactive delirium with severe agitation. So there has been a push recently, like in the past several years, to get away from the use of the term excited delirium. And that is because excited delirium has, as was mentioned in like one of the Vice clip, has a lot of baggage attached to that term, and that it is associated with profiling, implicit bias, racism. So a more descriptive term so for example, the American Board of Pathologists, the people that like do autopsies, they will not list excited delirium as a cause of death anymore. They're like, nope, excited delirium, that has a bunch of other things associated with it. This is the medical term we're going to use, which is hyperactive delirium with severe agitation. American College of Emergency Physicians is on board with this, and so is National Association of EMS Physicians. So you'll see here in the ACEP position statement, the term excited delirium should not be used among the wider medical and public health community, law enforcement organizations, and ACEP members acting as expert witnesses testifying in litigation. So I would encourage you to never ever write in a report that a patient has excited delirium. It should be, if you're going to say anything along those lines, hyperactive delirium with severe agitation. So this is probably the biggest study to date that's been done on pre-hospital ketamine use. This was done directly in response to the Elijah McClain case. And the people who published this research went and testified to the House and the Senate in Colorado about the safety of ketamine, because they were trying to pass a law that would remove ketamine from pre-hospital practice full stop in the state. And so this tempered a lot of what they did, because they did the research and the research went and testified before the state and the Senate, or the House and Senate for the state. So they looked at all ketamine patients, all 911 calls who received ketamine in 2019. So there's no comparison here. They're not like matching like behavioral patients that did or didn't receive ketamine. They're just looking what happened to all the people that got ketamine, and how many of them had a bad outcome, specifically mortality, because that's a pretty bad outcome. So they had 11,291 patients. Interestingly, about half of the administrations were for trauma or pain dose, and about a third were for behavioral. And the rest of the mix was like seizure and like some other stuff. There were a total of 128 deaths. 8 occurred on scene and 120 occurred at the hospital. And so they went through, and the panel of physicians go through the case, and they're like, can we say that the ketamine did not have a role in this patient's death, right? And so, interestingly, so a lot of the hospital deaths, most of the hospital deaths, the pain dose ketamine was being given to patients with end-stage cancer who were on really high doses of opiates already. And then they died in the hospital because they have end-stage cancer. And they're like, okay, yeah, no, the ketamine was not associated with this patient's death, for example. And so here's the details on the the pre-hospital deaths that they couldn't say the ketamine did not have a role. Someone who had severe agitation on meth, who got ketamine and then, became apneic, etc. And then someone who was agitated during a prolonged MVC extrication, was extricated 4 minutes after they got ketamine, and then went into PEA 5 minutes after extrication. Those sound kind of familiar, right? I almost guarantee it's not the same cases, but it's a common theme, right? Same stuff we've been talking about. People that are on other things have to be monitored more closely when you give them ketamine. And a patient with limited patient access, right? You have to monitor the patient. So this, again, sounds like the patient probably went apneic and it was unrecognized. And then in the hospital deaths, there were 2 cases where they said they couldn't exclude the ketamine as contributing to death. 5, again, pain dose, where the patient had cancer or was severe polytrauma. And they're like, well, we can't definitively say that the ketamine didn't play a role in this. And there was 1 case of RSI where the patient was altered, hyperthermic, a bunch of other stuff going on. Again, they can't say the ketamine didn't have part of it, but it was almost certainly due to the underlying metabolic issue that they were RSIing the patient for, right? You look at RSI as an intervention, and those patients have a high mortality rate going forward, because if you're sick enough to need RSI in the field, you already have a very high risk of death, right? So that's where we get into things being association, causation, that kind of stuff. So there's a lot of association here. And so again, most of the time in these deaths, the ketamine is an innocent bystander. So consensus statement from NAMSP, International Association of Fire Chiefs, International Association of Police Chiefs, on collaboration between fire, police, EMS during acute behavioral emergencies. The key points from this: number 1, duty to act in just culture, right? Essentially that you are there and it is your job that you're going to be sort of advocating for the patient. And so that's your duty to act. And then we need to have a just culture where when you say no, I don't think it's appropriate to give the patient ketamine, that there's not going to be repercussions on you. Determining whether is this a subject/detainee or is this a patient, right? And making that distinction very early on to dictate what the course of action is going to be. That the patient has to have a medical evaluation. Again, ketamine is a medical intervention, so it requires a medical evaluation first. So you know, what am I giving this for? And what do I need to be worried about after I give it? Just like every other drug you give. Restraint and patient positioning specifically. A decision to utilize pharmacologic management shall be made solely by EMS based on their independent patient assessment and in strict accordance with EMS protocols and medical director oversight, right? So, right, the cops aren't the ones giving the ketamine, you are. So you need to be following your protocols based off your assessment. Which, when I say this out loud, it sounds silly, but it still makes sense, right? It's sometimes you sometimes you have to say the quiet part out loud, right? Full monitoring as soon as possible. Not a restraint with a key. Okay, if you are going to physically restrain the patient, this should be Velcro restraints, not handcuffs, not a posy where it still has a special key to be able to unlock it. Should be Velcro restraints or something that can be unbuckled, untied quickly if the patient is going to be physically restrained. Not with hands or feet behind the back, so you're not hog tying the patient. And not prone. So don't sedate a patient and then restrain them face down. Don't put the airway into the cot after you sedate the patient, okay? And another thing that I'll add, so the safest way to restrain patients is, we call it swimmer's position. So that's one arm up, one arm down. And that's because if you have both arms up, that can cause some respiratory difficulties. If you have both arms down, they can headbutt you. One arm up, one arm down fixes this. The other tip, if you are going to restrain someone, is the feet. You want to restrain each foot to the opposite side of the stretcher, because if you're on the same side of the stretcher, you can kind of move your foot around like this. If this is the foot, this is the corner of the stretcher, right side, you have a radius that you can kind of flop around in. But if you are tied to the other end, you can't move except towards it. But at that point, they're crisscrossed, right? Because you switch side to the other end, so you can't move your feet against each other. So tying to the opposite side is the better way to go for it. All right, so let's talk about our mass protocols. We're going to talk about each protocol that has ketamine in it. Number one, the one we're probably mostly thinking about is behavioral health. So 4 mg per kg IM only up to 400 for a single dose. You know, MedCon can order repeat, blah, blah, blah. The thing that might blow your mind a little bit here is that this doesn't specify which patient weight you should be using, but ketamine is generally dosed off of ideal or adjusted body weight. How do you figure out ideal body weight? There's a formula. What are the inputs of the formula? Height in inches and gender. That's it. So now, instead of trying to channel your inner carny and estimate someone's weight based off their appearance, now all we're doing is guessing how tall they are, which we're probably going to be better at, right? So this is, you know, the distribution of heights for men versus women. For men, the average is basically 5'9", and for women, it's 5'3.5". So so my point in showing this is that it's a bell curve, right? And so given that doses are within ranges, and if you're estimating a height or using an average to estimate, that's going to be close for, if you're using an average, it's going to be close for most of the patients, right? Because most of the meat of the bell curve is in the middle around the average, right? Does that make sense? Okay. So ideal weight is height, basically, right? It's based off of height. So for men, you got an average height of 5'9". 68% of men are going to be between 5'6" and 6 feet tall, which means that for 5'9", the ideal body weight is 70 kilos. And so 68% of men are going to be between 64 and 78 kilos. Okay. So you can ground your estimation of the patient's ideal weight around that. That if you're like, call it 65 and 80, right? That you're going to be right 68% of the time for a man of average height. And for women, the average is 5'3.5". 68% of women will be between 5'1" and 5'6". And so the ideal body weight for that 5'3.5" is 53 kilos. And then so 68% of women will be between 48 and 60 kilos, ideal body weight. So again, we're still estimating a weight. We're still going to do appropriate weight-based dosing, but we're only looking at the height and knowing what the average is, if adjusting up or down, the math is a little bit easier, and we're probably going to be more accurate because, again, ketamine generally dosed off of ideal or adjusted body weight. I don't want to get into adjusted body weight because then you have to know their actual weight, and you're taking a fraction of their actual weight and adding it to the ideal weight. Too much, not going to happen on scene. And then, again, you can always give more. I mean, you have to call, but. So, pain and nausea management. So for pain, we're doing 0.15 IV IO slowly with 1 repeat dose. So total of 0.3, or you can do 0.3 nasal or IM once. Now, this is where I hear people kind of struggle with it because the ketamine that you guys get is so concentrated, right? It's really difficult to give the patient the right amount. Well, and I'll talk about that in just a minute. But so the ideal patients to get ketamine for pain control are people that are opiate tolerant, right? And that's either because of street use, right? They're on fentanyl, or they're in recovery and they're on methadone, Suboxone, something that's already occupying the receptor, or they have cancer and they're on high doses of opiates for pain control already, right? So someone who's very opiate tolerant or are you trying to avoid opiates? They're a really good candidate for ketamine for pain control, or someone that has a fragile blood pressure, right? So you've got grandma who broke her hip and her pressure's like 90 systolic, right? And you're like, if I give her fentanyl, she's probably going to tank, right? Because she is a good candidate for pain dose ketamine, because ketamine does not tend to affect hemodynamics as severely as opiates do, even fentanyl. So, and that's part of the correlation that we see, like with the trauma patients. If you have a sick trauma patient and you think they're too sick in terms of the bad outcomes, if you have a sick trauma patient and you think they're so fragile blood pressure wise that fentanyl is going to tank them, so you give ketamine as instead, right? There's a reason we gave the ketamine. Right? This is called confounding by indication. So those patients, like, it's not that the ketamine caused like the patient to do more poorly. It's that it is a marker of patients that were at risk of doing poorly to begin with, right? They probably would have done worse if they'd gotten a big slug of fentanyl, right? And this is why we need, when we do research, we like to have prospective randomized control trials, because it takes the bias out of something like that, because they're getting randomized, right? And so we can compare the patients directly, but we can't do that when we're doing the kind of database studies that we're able to do right now with this. Sedation for an intubated patient, you're looking at 1 to 2 mg per kg, slow up to 100. Now, this is, right, so the reason that this is a hard stop of 100, you're like, well, I treat plenty of patients that look like they weigh over 220 pounds. Again, that's ideal body weight. So you have to be quite tall for your ideal body weight to be 220 pounds. That's why there's a hard stop on there. Just as a reminder, this is after intubation, not to facilitate intubation, okay? Medication facilitate intubation, AKA half of an RSI, is not a thing in the protocols. Don't do it, don't ask. And then sedation for cardioversion. It's essentially the same thing. So it's 0.1 to this. It's odd that it has a higher dose than the pain dose, because 0.5 is going to put your patient right in the recreational range. So they'll be screaming about the dinosaur tap dancing in the corner as you're lighting them up to get them out of AFib. Like, well, yeah, I guess like they didn't feel the shock because they were too distracted, right? Like, because there's an invisible dragon. Like, what? Like, so I don't know why that's the way it is, but I would just do the 0.3 pain dose if you were going to use ketamine for that. Although generally, if you're cardioverting the patient, it's probably because they're unstable, and hopefully they're unstable enough, but they're probably unstable enough that you won't have time necessarily to sedate the patient, and they will probably be out of it enough that they won't remember. And if you give the Versed like right afterward, or like right after the same time, hopefully you get some of that retrograde amnesia, and then they won't remember. So let's talk about safe IV administration of ketamine. So the ketamine that we normally give you guys is 500 milligrams in 5 mLs. Sometimes it's 510. So we're going to take this vial, which is the IM concentration, and we're going to use 2 tools to be able to deliver this more safely. This is mostly specific to the pain dosing and possibly to the IV for intubated sedation dosing. Okay, so we're going to use a flush, and we're going to use a 100 cc bag. You could use a 250 too. It doesn't really make a difference. So for pain dose ketamine, you're going to take your flush. You're going to waste 1 cc. So this is now a 9 cc flush. You're going to go to your ketamine vial, and you're going to use that flush to draw up 1 ml. Okay, so my flush is now, instead of being 100 per milliliter, is now 10 per milliliter. Okay, now label that flush. Okay, right, label that flush. Now, if you are going to give pain dose and you are okay with trying to slowly push 1.5 cc's out of there, because you're going to give 15 milligrams or whatever, that's fine. Personally, the rule of thumb here is that whatever you are connecting to the patient, whether it's through an IV line, through a needle for IM, in a bag, whatever you're connecting to the patient, if you give the whole thing, it should not be, and it's not on a pump or whatever, it should not be harmful, okay? So if I give the patient 100 of ketamine IV, is that going to make them explode? No, it's going to completely dissociate them, and it's not what I meant to do, but it will not kill them. They could go apneic and they still the monitoring and everything we talked about, but the point is the thing that I'm connecting to the patient in and of itself, if I accidentally give the whole thing, is not lethal, okay? Now, you're going to take your mini bag and you're going to add your desired weight-based dose. So you can, so what I would do is if I'm using, you know, an estimated weight of 100 kilos, I'm probably going to be giving the patient, depending on weight, again, somewhere between the two doses, somewhere between 20 and 30 milligrams of ketamine. So I'm going to take that mini bag and then I'm going to add by total dose the 0.3 in there. So it's going to be, you know, 2 or 3 cc's added to the mini bag. I'm going to label that bag, okay? And then I'm going to run it open or run it half clamp, okay? So, and I can watch, because you can watch and make sure you give half the bag, okay? And again, if I give the whole bag, not harmful. Technically protocol violation because I didn't give one, wait 15 minutes to give the other, but not harmful. So now, 2 important things. Number 1, we've got that reduction so that the worst thing that happens is I gave both doses instead of 1, right? So that what's attached to the patient is not going to be harmful. And number 2, the reason that people have poor reactions to pain dose ketamine is generally because of the speed that it's given with. And you do not have the attention span to push that 1.5 to 3 cc's over 5 minutes. You don't. No one does. Pharmacists do. I've seen them do it, and it's amazing. I'm like, remind me not to play poker with you, sir, because you can actually concentrate. So, but you don't. You don't have time for that. So that's why I do the bag, and this is what I do with ER nurses too. When I do pain dose ketamine, is I say, and they love it. Just like, oh, I just hang it and forget it and walk out. I'm like, yes, because I know if I tell you 5-minute push, it's going to be 45 seconds. Because ain't nobody got time for that. So add it to the mini bag, and then you can run it in. You know, if it's a 250, you do it wide open. If it's a 100 bag, do half clamp. Because a mini bag at half clamp will take about 15 to 20 minutes to go in to the patient-ish. You can play with it next time you're on shift, right? So now you can keep glancing over, and when they get half the bag, clamp it, reassess their pain, and if you want to repeat the dose per the protocol, just open the bag and let them get the rest. Pretty simple, right? So diluting it down into manageable amounts it's a little bit extra work and it requires a little bit of extra steps, but it's 100% the safest way to do it, right? If you want to give 100 of ketamine IV, don't draw up 500 and then promise yourself that you're going to give 1 milliliter, right? That's a recipe for an accident, right? Like that's how mistakes happen. Even drawing up the 1 milliliter is going to be challenging to administer because 1 milliliter, like most of that is going to get stuck like in the lure lock and the needle. Like that's just a small amount. That's why we dilute it, right? So now I have, now I have 110 and 10 mLs. Now I can push that whole thing and I know that's actually like getting it. Okay, it's the other reason for doing the dilutions. All right, so let's summarize what we have learned today. Number 1, ketamine is overall extraordinarily safe, right? The adverse effect rate from that large study that was done by ESO, mortality, other bad stuff, less than 0.1% of pre-hospital administrations. So even when something does happen, it's extremely rare, right? Evaluate your patient before you administer. Ketamine is a medical intervention that requires a medical assessment be done first. You can always give more, but you can't take it back. Remember, Protocol 1.0 says you can take any medication and you can divide it up and give it in smaller amounts. Okay, you're allowed to do that. Co-intoxicants increase the risk of adverse events. So if the patient is super drunk, super methy, super PCP, super cocaine, right, they're higher risk of having something bad happen. Again, not from the ketamine itself, but from the underlying metabolic problem that those intoxicants are causing, especially if they're on, if they're drunk, right? That's also sedating. So if you mix two sedating meds, the risk of apnea is increased. So you need to be more ready than usual to manage the airway, as opposed to someone that's, super upped on, cocaine, PCP, whatever. They're less likely to have the airway collapse issues, but they're at increased risk of metabolic stuff from all of the acidosis, hyperthermia, and other things that are going on. Your patient has to be monitored. Has to be monitored. So be ready to put the patient and monitor the patient as soon as you give them the medication, right? When I am giving ketamine, because I do this like for really agitated trauma patients or really agitated medical patients, and I'm like, I need to know if you have a brain bleed and you are not going to be able to sit still for the scanner, right? I'll give them 100 ketamine IV or, 250, 500 IM to facilitate. And I've had to do this without IV access before, but they're already on the stretcher in either the trauma bay at Bay State or in one of our recess rooms at Mercy, because I'm right there. I'm ready if anything happens, right? And so I give the IM med. Now they're relaxed. They're not fighting. I'm like, okay, get them on the monitor, full set of vitals, POC. Let's get access. Let's get our labs, and then let's make a run for it to the CAT scanner, right? Because it lasts about long enough for me to get all of that done. And then I go, okay, sugar's normal, not a brain bleed. I need to be looking for other stuff now based off of all that blood that I drew before. So I think of it as sedation to facilitate the rest of the workup. And for you, it's going to be sedation to facilitate getting access, vitals, and safe transport to the hospital. Be ready for immediate airway management. This can happen very quickly. So like have your hand on the airway bag, petting the BVM for good luck to ward off evil, right? So you're like ready to go. But if you need to be ready for immediate airway management, what else should you be doing when you're administering the ketamine? Pre-oxygenate, maybe, if that's feasible, sure. Assess what are you assessing about the patient? Yes, okay, yes, making sure they're still breathing. But you need to be thinking about, does this person have features that are going to make their airway difficult to manage? Okay. Do they have a big old beard? So does that mean the BVM is going to be a problem? So does that mean I need to think about what size LMA I would use? Okay. What size tube would I use if it comes to that? Where's my crike kit? Right. The same things you think about on every patient that you're going to have to manage the airway on, you need to be thinking about when you administer ketamine. Because it's just really good practice when you see a patient to be doing I call it an airway size up, right? Same way you do scene size up, airway size up with every patient. You need to be doing that with ketamine. You need to do an airway size up. And, okay, am I going to be able to bag this patient? Do they have dentures? Are they edentulous? Do they have meth mouth? Are they going to be impossible to bag? Do they have no neck? Like what I'm thinking through all of the possibilities so that I don't have to think through that when my adrenaline is up because things have gone wrong. I think about it when my pulse is lower, right? So I have a plan. Other reminders. So for your patients with chest pain, remember that Mercy has a 2-hour MI rule out, whereas Bay State it's a 4. So perhaps instead of strictly saying, where do you want to go? Or where do you usually get your care? Say, hey, you're having chest pain. You're probably going to need blood work to determine whether this is a heart attack or not. At Mercy, that can be done in 2 hours. At Bay State, that takes at least 4. Where do you want to go? We're able to get them in and out of the ER significantly faster, not just because of our protocol and how it's accelerated compared to Bay State's, but because we actually get the labs drawn on time because of our staffing. Mercy does have an ICU. It's small, but we do have one. So we can take care of your sick and critically ill patients. So if you're using if you're using a pump, if you're putting your patient on pretty much anything that requires a pump, if you are using that presser quick reference card, it's a reminder to bring the patient to us because we can take care of them, right? And our phone numbers are right at the bottom there, making it easier to call report. Cerebell, like we talked about at the Neuro M&M, is a point of care EEG that we have in the ER. So if there's a patient with altered mental status, I can put that on and within 15 to 20 minutes know if they're having non-convulsive status. So if their brain is seizing but their body is not. Baystate does not have that ability. For a patient to get that kind of testing, they either have to convince someone from the neuro ICU to come down and hook up the patient or get the patient up to the neuro ICU, which can take hours, if not days. So we are better equipped. So the perfect case for this is a seizure patient who's not waking up normally. They may still be having seizure activity in the brain, but not seizure activity in the body. And so we have the ability to get that diagnosis quickly and then treat the patient correctly. Baystate does not. They don't have that technology we do. So you should bring those patients to us. All of our recordings are at mercymedcon.org. Please go there and join the email list. I'm not going to spam you. It's only going to be reminders about M&Ms, trainings that are coming up, other educational opportunities, or stuff like, hey, family life, closing up on December 8th, important things. Probably not pictures of my dogs. No promises. Next month will be our last M&M for the year. I am hoping to do interesting or challenging EKG cases. So if you have them, either email them to me and Renee or go to mercymedcon.org and use the case submission form. Either way, if you have interesting or difficult EKG cases, send them my way so that we can feature them in the M&M. I'm hoping that'll be a good one. And our 2026 M&M schedule is posted. So if you go to mercymedcon.org, down to the calendar, all of the M&M dates for 2026 are already out there, and you can register for them up front. Any nurses that are out there, if you happen to be listening, that's your link to get CME for this, or if you want nursing credit because you have both licenses. If you're not able to scan this in time, just shoot us a quick email, mercyems at trinityhealthofny.org, and we can send you the link afterward. And that's what I have. Please scan the QR code and take the feedback survey. Let me know what you thought about this. I know it's a little bit different than some of our other M&Ms because this is all cases that have been in the news, not local cases. Let me know how you felt about that. And that's all I got. Thanks everyone for coming. Yes, November 21st, there is some stroke education with St. Francis. Okay, it is virtual only and you get mass credit for it. Let's make sure we get that to marketing so it gets put on the calendar with the rest of the stuff. Share already did. Okay, so you can go to mercymedcon.org, go to we'll double check that. If it's not there already, we'll get it on there so that you can register mercymedcon.org, stroke CME on the 21st. All right, thanks everyone.